Good morning, everyone. Today's case is Ewing Sarcoma of Sacrum. 29-year-old man presented with pain in the sacral region and radiculopathy. His imaging revealed loss of normal lumbar lordosis and an expansile altered signal intensity lesion at S2-S4 vertebra involving left ala of sacrum. It was also involving the sacral foramina and associated with abnormal soft tissue in the pre-sacral and post-sacral region. A possibility of metastasis was suggested by the radiologist. In our lab, we received CT-guided true-cut biopsy. Microscopy revealed a small round blue cell tumor. Now, this tumor was composed of round to oval neoplastic cells arranged in sheets, nests, occasional rosette, and perivascular pattern. Bony infiltration was noted. The cells had round to oval nuclei and finely stippled chromatin, and the cytoplasm was scanty, and you can see it is clear to pale eosinophilic. Some mitotic activity was noted. The intervening stroma was scanty and showed mild diffuse infiltration by lymphocytes. Desmoplasia was absent in the stroma, and you can see here that there are areas of necrosis. So the differential diagnosis we thought of was Ewing sarcoma. Another possibility was desmoplastic round cell tumor, but desmoplasia was absent here. Significant desmoplasia was absent. Possibility of lymphoma, and whenever a tumor which shows presence of homocyte rosettes or ganglionic differentiation, one must think about possibility of peripheral neuroblastoma. Another is solitary fibrous tumor. However, the solitary fibrous tumor, they also exhibit CD99 positivity, but they are STAT6 positive, and Ewing sarcoma are STAT6 negative. Another is a typical teratoid rhabdoid tumor, which also exhibits CD99 positivity, but the tumor cells show loss of INI1 expression. So we went ahead with immunohistochemistry in this case, and we had CD99, FLI1, and NKX 2.2 positivity. So this confirmed our diagnosis of Ewing sarcoma. We did LCA, which was negative. The lymphoma was ruled out. Cytokeratin was focally expressed. We did desmin, which was negative. That ruled out possibility of desmoplastic small round cell tumor. And the Ki67 proliferation index was 35 to 40%. So a diagnosis of Ewing sarcoma of S2 to S4 was. Ewing sarcoma was named after Dr. James Ewing, well-renowned American pathologist at Memorial Sloan Kettering, New York. He had pioneering work in neoplastic diseases. Years later, MSK doctors were first to identify the genetic change unique to Ewing sarcoma. I feel privileged to gain my neuropathology experience in the same institute. Now coming to discussion, it is an extraosseous small round cell sarcoma showing gene fusions involving one member of the FET family genes, usually EWSR1, and a member of E26 transformation specific, that is ETS family of transcription factors. It is the second most common malignant tumor in children and young adults after osteosarcoma. Males are more affected than the females. The peak incidence is in the second decade of life, and nearly 80% of patients are less than 20 years of age. These tumors may be sporadic or idiopathic. Chromosomal translocations commonly involving EWSR1 and ETS partner. The cell of origin is possibly the mesenchymal stem cells. Now, these patients, they present with localized pain and swelling. The mass is usually painful and enlarging, and it may be associated with pathological fractures. Systemic findings, one may find fever, weight loss, anemia, leukocytosis, and raised ESR. So basically, a diagnosis of Ewing sarcoma is integration of clinical, radiographic, immunohistochemical, and molecular information. On imaging, that is on plain radiograph, the lesion is osteolytic permeative with poorly defined margins, having moth-eaten appearance or moth-eaten destruction of the bone, aggressive periosteal reaction, which may look like onion skin appearance, is present. Sunburst periosteal reaction is less common than those found in the osteosarcomas. Saucerization and extraosseous tumor erodes the cortex. There is no evidence of tumor osteoid or matrix production in Ewing sarcoma. On CT scan, MRI, or PET, the lesion is fully defined primary lesion. Soft tissue extension may be present. It may present in form of a metastatic disease also, so it is better to do the whole body screening. These lesions are low to intermediate signal intensity on T1 and heterogeneous on T2. So the diagnostic criteria for Ewing sarcoma as per WHO CNS 5, the essential criteria are the tumor should have a round cell morphology and CD99 diffuse membranous positivity and FET ETS fusion. Now this is a diagnostic molecular information and this can be done by FISH or NGS. And in the desirable criteria, NKX 2.2 and PAC7 positivity. Prognostic factors. Presence of metastasis has bad prognosis. Localized resectable disease with 5-year survival rate of 70% and metastatic disease has a 5-year survival rate of less than 30%. In treatment, patient outcome greatly improves with induction of chemotherapy followed by tumor resection and radiation therapy. Chemotherapy improves prognosis to 75% for 5-year survival rate. Thank you very much. You can contact me and give me some feedbacks and also like and share my video. Thank you very much.